Well, Michael, thank you very much for the introduction and the invitation to participate in this COSIN event. I'm very honored to be with Dr. Forrester and Tom Kulik. And I do remember both of you very well from your days as house staff at the University of Minnesota in pediatrics and also in our training program. And I know Russ Lucas, who was our division chair, would be very proud of both of your accomplishments through the years. And I would congratulate you as well and wish you the very best in the years to come. In this talk, I want to talk about some of the fascinating stories of the beginning of open heart surgery. And all these events took place on the campus of the University of Minnesota. And this is a picture in June of the main campus of the university. This is looking down the mall. Oh no, this is January, not June. And the Kaufman Union is behind me, and you can see students here. And all the events I'm going to talk about occurred here at the campus, on the campus, and during a period of time of about 6 or 7 years. And this is the hospital where the initial open heart operations were performed. It's called the Mayo Memorial Hospital. The operations were done on this wing of the hospital after 1956. Before then, it was done in another area of the hospital. And there are 2 operating rooms for cardiology, and one was for Dr. Lillihai's service, and the other is for Dr. Varco's service. And from here, the patients were moved down 2 long corridors to the postoperative area for recovery. And after that, once they're out of the intensive care unit, they moved to this hospital. This hospital, which is the Variety Club Heart Hospital. It was built in 1952 and had about almost 80 patients. The 3rd floor here was for children. There were about 39 children with cardiac problems, and the 2nd floor had 39 adult patients with cardiac patients. There's a catheterization laboratory here, and also a clinic and offices for cardiology. My current office is right here. This is no longer a hospital. It's a research building on the campus. This is on a bluff overlooking the Mississippi River, which runs through Minneapolis and St. Paul on its 1,000-mile journey down to New Orleans. Well, we're very lucky in Minnesota to have a large population of people of Norwegian heritage. And one of these was Dr. Owen Wagenstein, who was appointed chairman of surgery there at age 32. And he helped develop this department into one of the strongest departments of surgery in the United States. He had training after his surgical training at the Mayo Clinic. He went to Switzerland to study for a year to see what the training methods were in Europe. And he saw that a lot of the surgeons there were doing animal research. And this had a profound effect on him because as he came here to have fellows in surgery, he encouraged many of them to get a PhD. And I think all the surgeons I'm going to talk about today, except maybe one, is an MD, PhD. And you think about these people, they went to medical school, undergraduate studies and training in cardiology and surgery and cardiac surgery, and then a PhD. And they always hoped that they could finish this by the time they had to start taking Social Security. It was a long period of time. And among his trainees, and the ones that he was particularly proud of, was Norman Shumway, the father of cardiac transplantation, Dr. Bernard, who did the first heart transplant in South Africa. John Willis will talk about, Dr. Lillihei, Dr. Dennis, and Dr. DeWall. I'll talk about each of them in a bit. Well, it's amazing cardiac surgery got started. We had to follow what Dr. Bill Ross said in 1875, that any surgeon who would attempt an operation on the heart should lose the respect of his colleague. And this was such a strong dictum that it was 76 years until the first open heart operation was done. It's interesting, Dr. Bill Roth played the violin and was a friend of Johannes Brahms, a classical composer. And Bill Roth is in a string quartet in Vienna, and sometimes Brahms would send a string quartet, the music for a string quartet that he was working on to see how it would work out. And ultimately, Brahms dedicated 2 of his string quartets to Dr. Bill Roth. Well, you know, in talking about congenital heart disease, sometimes it's hard to follow where the blood's going. But this 4th grade boy had the answer. The arteries carry blood either to the heart or from the heart. I don't remember which, but the body does, and that's what's important. And my knowledge of cardiology and physiology is a little bit more advanced than that, but I don't know how much more. Well, this shows what the status of cardiac surgery for congenital heart disease was in 1953. This is an article in a publication of the American Heart Association by Alex Natus, who is a premier pediatric cardiologist at Boston Children's. And you can see there's really 3 conditions that were treated: patent ductus, coarctation, and tetralogy of Fallot. And all of these are outside the heart, between the great vessels. And it was amazing to me to look back at this at the optimal age at operation. And these are all in terms of years. And you think about now, we talk in terms of months and days, and sometimes even hours. So it's a very different situation back there nearly 70 years ago. And there's a mention here, isolated pulmonary stenosis and atrial septal defect, which were just in the development at that particular time. Well, thinking about the early attempts to open heart surgery using a cardiopulmonary bypass in 1952 to 54, several surgeons performed such operations. Clarence Dennis here at the University of Minnesota, John Gibbon in Philadelphia, Helmsworth, Dodrell, Cloves, and Dr. Muster. And the combined group operated on 18 patients, and only 1 survived. And that was a patient of Dr. Gibbon. So it was a rather dismal situation, and people were discouraged. But here's a picture of Clarence Dennis, who did the first open heart operation. Clarence Dennis was born in St. Paul, Minnesota, went to Harvard and then to Johns Hopkins Medical School, and then came back here to the University of Minnesota. He's a very young-looking person, and sometimes when he was a professor, he'd walk into the patient's room and they thought he was just a resident, because of his appearance. But he was a very capable surgeon and did the first open heart operation using the Pumpoxidator. And here's an article that they wrote, development of a Pumpoxidator to replace the heart and lungs, an apparatus applicable to human patients, and an application to 1 case. You can see this is obviously from Minnesota, because here's a Nelson, a Carlson, and a Nelson. and only in Minnesota could you have a group of Scandinavians together on a paper. I also like to emphasize the fact that here was the name Richard Varco. And Dr. Varco is a very senior professor here, surgeon, and was for any of the original types of operations, he was always an assistant because they could depend on his judgment and surgical abilities. This patient that was operated on was a 4.5-year-old girl who was referred by Forrest Adams. And I don't know what the name Forrest Adams means anything to you, but that's the Adams of Moss and Adams, the textbook Moss and Adams. Art Moss was from St. Paul, Minnesota, and Forrest Adams was from southwest Minneapolis. In fact, lived not too far from where we live today. And he referred this patient, and I always knew about this patient and the fact that they had operated on the patient and were unable to close a defect because of the tricuspid valve. And five years ago, when I was over at the Edwards Registry of Cardiovascular Disease, where there's 27,000 heart specimens, I was going through the files. And each case that they have, those 27,000 cases, it has a very detailed written description. And as I was going through the files, there was a single piece of paper written in Dr. Jesse Edwards' handwriting. And he said, "This is the first heart to undergo open heart procedure." Well, I quickly pulled out that specimen, found that specimen, and here's what it showed. This is a picture of the right atrium, a right ventricle, which is open. It'd be going out this way to the pulmonary artery. And this is the level of the AV valve. And here is this defect low in the atrial septum adjacent to the tricuspid valve. And if you look at the tricuspid valve, this should be the septal leaflet of the tricuspid valve. You can see part of it here and part of it here. And so this is a cleft in the septal leaflet of the mitral valve. And I don't even quite appreciate it, but the valve tissue goes through the defect and is continuous with the mitral valve over here. This is the left ventricle. This is the left atrium. Here is a defect, again, low in the atrial septum, adjacent to the mitral valve. This should be the anterior leaflet of the mitral valve. You can see a deep cleft in here. So this defect was not an ostium secundum defect, which they expected, but an ostium primum defect with a cleft anterior leaflet of the mitral valve. Now it's interesting that this patient had left axis deviation. And early, before echo, the way we recognized that somebody had this defect was identified it by the fact that they had left axis deviation. And I looked in an early textbook of pediatric cardiology by Dr. Tausig. And in her book, she describes each cardiac malformation in a separate chapter. And there's always a section on an EKG. And they're very nicely outlined what the major findings would be. But an AV canal, she really didn't say. And it really, I don't think it's probably to 1957, 56, 55, where the association between left axis deviation and AV canal was fully identified. Well, this patient died, and did another patient a couple weeks later. And one of the situations then, there was no dedicated or technicians to run the pumps. So if you were the resident on the service, it was your responsibility to run the pump. And so on the second patient, the house staff, the person who was supposed to be watching the oxygenator, was so entrenched that and enchanted that he started looking at the operation. As a result, the pump ran dry, and the patient got air embolus, and they worked like the devil to help solve that problem. The patient passed away. And 4 months later, Dr. Dennis left the University of Minnesota and became a department chairman of surgery in New York City, and ultimately did the first open heart operation in New York. Well, sometimes congenital heart disease is complicated, but Norm Shumway had 3 axioms. Air goes in and out, blood goes round and round, and oxygen is good. And so the air comes in and out of the lungs, and the oxygen is supposed to be picked up as the blood goes through the pulmonary circulation. But if you're going to open the heart, you have to disrupt that system, blood going through the lungs. And so it was always a challenge, and that's why they're trying to develop these heart-lung machines. Well, between 1951 and 1955, at the University of Minnesota, several techniques were used before we finally had an oxygenator developed in 1955, other than the one that Dr. Dennis had in 1951. And these methods, and we'll go through each one of them individually, were profound hypothermia with inflow occlusion, using arterialized venous blood placed in a reservoir to perfuse a patient, using an isolated dog lung as an oxygenator, or with cross circulation with a relative. Well, this is a picture of F. John Willis. And I know Norm Shumway always felt that Willis is equally smart to Seawalt Lillihigh. You know, my secretary for 40 years used to work in the surgery department, and she could see into the office where Lewis and Lillihigh worked. They worked in the same office, but they didn't communicate much to one another, and kind of kept their own ways. But F. John Willis did this operation of using hypothermia and inflow occlusion. So they lowered the patient's body temperature to about 82 degrees so that the systemic oxygen utilization would be limited, and then had ties, loose ties around the major venous pathways into the lungs, or into the heart. And initially, they made an incision in the right atrial appendage and inserted their finger in there and to palpate where the atrial septal defect was. And then once they had identified that, they clamped off the blood flow and made a right atriotomy. And through the right atriotomy, they could look in and see the defect. And it's important that in closing these defects, they started sewing at the lowest part of the atrial septum and sewed the defect up until it was eventually closed. They used 3/0 silk sutures, and here they had the defect closed. Then they came out and put a side clamp on the atriotomy and could sew that up as they allowed blood to flow back through the heart. So they had this patient now who was had the defect closed and was hypothermic, and so they had to warm it up. And I don't know if you've gone through countrysides and seen these galvanized horse troughs, and they're about 6 feet long, about 2.5 feet deep. And if you took out the crossbar, you could, and had warm water in here, you could put a patient in there and warm up their body temperature. And so they had two of these horse troughs up in the operating room, and you could get them at Sears Roebuck for about $29.95 in those days. So that, I mean, I tell you, they did a lot of things on the cheap in these early days, but it took about a half hour with the patient partially submerged in 104-degree temperature water for the patient's body temperature to become normal. And Willis said in repair of the atrial defect with hypothermia and inflow occlusion, hypothermia allowed open heart repair in a bloodless field without a specialized team of assistants, without heparinization of the patient, and without special blood donors. So it had a lot of possibilities, and he did mostly atrial septal defects. He did try this unsuccessfully in a couple of patients with ventricular septal defect. Well, he did 61 patients, and thinking about this is 1952, 53, 54, and had 6 operative deaths. That's 10% mortality. And most of the patients were older. 2/3 of them were over 16, and the oldest survivor was 61 years old. It's interesting to me that the amount of time that the atrium was open was 3 to 8 minutes, and most of them around 4 or 4.5 minutes, which is really remarkable to think about slowing up that atrial septal defect in that limited amount of time. And here's information about the temperature. Initially, about 11 patients fibrillated, and they learned that their temperatures were in the upper 70s, and so that after that they kept the patients, never lowered the patient's temperature more than 82 to 82 degrees. And this is from the autobiography of Thomas Starzl, who is the author of hepatic transplantation. And he wrote about F. John Willis, in medicine, he will always be remembered as the first person to operate inside the open human heart. His protege at Minnesota was Norman Shumway, the father of heart transplantation. I was Willis's protege at Northwestern. So it shows the remarkable strengths of this man who not only pioneered in cardiac surgery, but helped develop the careers of 2 people who developed their own areas, unique areas in surgery. At this time, in 1956, F. John Willis moved to Northwestern Hospital in Chicago, and became the first and only full-time faculty member in the Department of Surgery. The chairman of surgery at Northwestern Hospital was named Loyal Davis, and a friend of ours, his father was head of radiology at Northwestern, and said Loyal Davis is the biggest poobah in Chicago. And Loyal Davis had a daughter named Nancy, who wanted to become a movie actress, and moved to Los Angeles, and ultimately married a man, a movie actor, and eventually they moved to Washington, D.C., and lived in a big white house on Pennsylvania Avenue, and her name was Nancy Reagan. Well, the next technique that was used was illustrated here in this 6-month-old baby of a system where you fill up a reservoir, about 8 liters of oxygenated blood, and run through a pump and put the arterial blood into the child's aorta, and take the vena cava blood out through a pump and here to the venous reservoir. And the blood that they put in here in this was arterialized. And so they had a patient and had a large needle in the medium basilic vein and wrapped the arm in warm, I'm sorry, and wrapped the arm in with towels at about 104 degrees. And when you drew the blood from the vein, after about 20 minutes, the saturation was 94%. You think about this, the arm is immobilized, so it wasn't using oxygen. And with the warmth, vasodilated blood vessels, so the hand essentially became an AV malformation. And so they could withdraw that blood. And the hemoglobin would hold on to that oxygen for at least 2 hours so that they could place that arterialized blood in this reservoir. They had to have 8 blood donors of the same blood type, obviously, so that was quite a hassle for the families to identify 8 friends who could come down and donate blood for their child. This little child had that VSD repair, and I saw him 26 years later. He came back for a checkup, and he's the only patient I ever had that showed me a photograph of his VSD in person. And we checked with him again when he's in about 65 years old. He's living in Little Rock, Arkansas, in a newspaper business, and he's still doing very well. But another way of trying to provide oxygen to a patient without using a heart-lung machine. Well, this is a story from Time magazine, and it talks about a boy, Calvin Richmond, from Pine Bluff, Arkansas. It's summertime. They're in Pine Bluff, and he was in the back of a pickup truck delivering blocks of ice for ice boxes. You know, now you people all know about refrigerators, but before there were refrigerators, people had ice boxes. It stood up and had 2 compartments, and in the bottom compartment you kept your food, and the top compartment was a metal line place where you could place a 25-pound block of ice. The ice would gradually melt, but it kept your food cool. And so periodically you'd have to get your ice replaced. Well, Calvin was helping deliver ice that summer, and the truck he was riding in ran into a bridge abutment, and he was thrown out and hit his chest on the pavement, and the impact created a ventricular septal defect, a traumatic ventricular septal defect. And they didn't know what to do with him, and they transferred him to the Children's Hospital in Little Rock, Arkansas. And the head of pediatrics there knew that the only place that they could get this repaired was the University of Minnesota. And she knew a member of the pediatric faculty named Bob Vernier. And I'm certain that both Tom and Michael remember Dr. Vernier, who is a very enthusiastic person. And so when they called, said, you know, Bob, can we send this patient up to you? And Bob said, oh, sure, of course, send him up. He said, well, there's one problem. This is there's no father, and the mother has tuberculosis and weighs about 85 pounds. And the Arkansas National Guard needs to be paid to transport him up there. So Bob and his wife, Moller, organized some kids from the Minneapolis public schools to collect nickels and dimes to get enough money to pay him, pay the National Guard to transport him up here. Well, he came up, and the only type of operation at that time that they were doing for ventricular septal defect involved using a human person as an oxygenator. And they went to the state prison to see whether one of the prisoners would be willing to volunteer to be that person. And none of them wanted to mix their blood with a black person. So they used this procedure in which they excised lungs from a dog and hung them here in this glass container and ran oxygen here. And they flushed out the lungs with dextran to get as much protein out of the blood vessels. And then they took the blood from his vena cava, here's his heart with the VSD, and took the blood from the vena cava through a sigma motor pump, which is a series of rods that moved in sequence across. Here's the tube of blood, a hard surface here. And so these would squeeze along here and move the blood this way. They move sequentially through here like in a waveform, and they carried on that arterial blood, or that venous blood, into the dog's pulmonary artery, and then collected the blood from the pulmonary veins in a funnel and ran it through another one of these pumps, through a warming bath, and into the aorta. Kind of a complicated system, but as we went along, you can see here he is post-operatively in the ward, looking very healthy. This person here is what we used to call a nurse. White starched dress, cap, and now your nurses wear pajamas. They look in scrub suits, and so it's very different. But here was Calvin Richmond, and I used to correspond with Calvin. It was always hard to keep up with him. He had aliases that he used, but he finally lived into his mid-60s in Los Angeles when he died, and was only sick for the last year of his life. Well, when we had the 50th anniversary of open heart procedures at the University of Minnesota, we invited back patients from about a 4 or 5 year period around the 50th anniversary. And at one of the meetings, a middle-aged woman came up to me and said, Dr. Moller, I'm a dog lung. I said, why are you a dog lung? Said, my father was in the Second World War and had yellow jaundice, and my mother had rheumatic heart disease, and neither one of them could be the person in the type of procedure Dr. Lillihei was doing, and they didn't want to ask any friend or relative to take that part. In fact, that was very nicely outlined in her medical record. So I had this dog lung. Well, we called her about 6 or 7 years ago to see how she was doing. Said, well, I'm doing very well. I haven't had any problems, and I'm just delighted. Our son was just admitted to Johns Hopkins Medical School, and in his application wrote about his mother's operation. And can you imagine being on an admission committee and coming across a letter that talked like that and expressed something like that? I mean, that would really be a major finding a major happening. And as a matter of fact, the head of cardiac surgery at Johns Hopkins was Vince Gott, who was one of the really high trainees. And I thought it was wonderful to get this young man and Vince together. But by the time I got to Vince, he had retired and was living in Charlottesville, Virginia. So, but this is another way that they use to provide oxygenated blood for the patient. Well, the procedure that I really thought to bring the beginning of open heart surgery is the one that was done by Lillihei, along with his co-authors Morley Cohn, Herbert Warden, and Richard Barco. I should say Warden is the warden of the Warden procedure for particular types of atrial septal defect. It was entitled The Direct Vision Intracardiac Correction of Congenital Anomalies by Controlled Cross Circulation. And they did this in patients with ventricular septal defects, tetralogy flow, and AV canal. And they used, had to use a parent or an adult as the oxygenator. And the day before the first operation, the head of the Department of Medicine at the University of Minnesota and the director of the hospital found out about this, and they wanted to cancel. They didn't think this should be done, and tried to stop it. And I didn't know all this until I got some information from a woman who was a daytime manager of the coffee shop I used to stop at. And she had two sisters who had tetralogy of flow, and I had taken care of them. And one day I went in there and she said, "Hey, Doc, I have some papers from Dr. Lillihei. Would you like to see them?" And I said, "Well, yeah, of course I would." And I said, "Well, I'll bring them in for you." And I got a folder of them. And in that folder was this note, and this is a copy of the original. It said, "Dear Dr. Lillihei, dear Walt, by all means, go ahead. OHW. This is Owen Wagenstein." I asked my secretary, Mary Jo, who had worked for Wagenstein, if this was his handwriting. And she said, "It is indeed." And so they did go ahead. And this is a picture of the first ventricular septal defect closure on March 26, 1954. This is Dr. Lillihei. This is Dr. Barco. This is Morley Cohn, Herb Warden, Norm Shumway, and Vince Scott. And they're working together. And you can see here, there's another scene, operating scene, a bloody scene here. And you look, here's the circulation that they had. This is the child. This is the parent. And they made an incision in the groin and passed an arterial catheter up into the descending aorta and a venous catheter up into the inferior vena cava. And they took the arterial blood out here through, again, one of these sigma pumps, where, again, it would massage the blood through, and this went into the child's aorta. And then the venous blood came out and through the other side of this pump into the parent's inferior vena cava. And so always the concern is the risk to the parent. And they did 45 of these operations, and only one parent had some CNS damage. The other parents did well. And I don't know where they got this idea. It said that Morley Cohn's wife was pregnant at the time they were thinking about this. And he said, well, here's one situation where one person is supporting the circulation of another. And this is a painting by Frida Kahlo, a Mexican artist, and it's called The Two Fridas. And you can see the blood is going from one into the other patient, other Frida. And here's a catheter with a forceps. And it's interesting that Frida Kahlo had a friend that corresponded with, I think, had maybe 250 letters back and forth. And that person is named Leo Eloesser. who was a professor of surgery at Stanford, where I went to medical school, and he retired to Mexico and became a friend of Frida Kahlo's. And he was a thoracic surgeon, and whether somehow that rubbed off into what this painting portrays. Well, they did 45 of these, and probably the most important points are down here below. At the time the heart was open was 4 to 14 minutes, the mean of 8. And my secretary, along with another secretary, were in the operating rooms during those early operations with stopwatches. And they were timing various aspects of the pump and the pump runs. And also they were there because they could take shorthand in case they wanted to dictate things to them. So it was an interesting experience for these two secretaries. They didn't have patch material, so they closed the defects with 3/0 silk sutures. And they had infundibular stenosis. They removed these by a Ranger instrument. And thinking about these operations compared to what we do now, these operations were done at normal thermia. There was no cardiac arrest. I have a movie that of the right ventricle from a ventricular septal defect. You can see that every systole, there's a shot of bright red blood coming through the defect. They didn't have intracardiac suction, no patch material. They couldn't measure pressures or oxygen saturations. There was no intensive care unit and no echo. Can you imagine? The only thing they had was a stethoscope. And postoperative drug therapy, they had no drugs ending in amine, no drugs beginning with the letter L. The term ACE referred to 4 of the playing cards in a deck. And the commonly used medicines were digoxin, penicillin, and mercurial diuretics. You now use Bumex. An interesting thing about Bumex is that when you mention the term Bumex to the nurse, the kidney hears that and immediately starts increasing the urine output. It seems like even before you administer the drug, it acts so quickly. Mercurial diuretic, such that you gave it today, and the urine output kind of picked up tomorrow, and it lasted up to a week. And of course, these days we had no prostaglandins. One of the other new things in medicine is electronic medical records. And I've read some of these, and they're often pages of laboratory data. And people must get so tired of typing in all the laboratory data that they forget to write what they're thinking about. But here on August 7th, 1954, after one of the first open heart operations, this paper medical record, this Dr. Monod wrote flourishing. He had no data, but he wasn't afraid to express what he thought. And I hope the next time I'm in the hospital, somebody will feel free to call me flourishing. And there were no specialized cardiac intensive care units or pediatric cardiac intensive care units. The patients went to just a general postoperative area. Here was in the hospital, and then they were transferred, of course, to the Variety Club hospital. Of the 45 operated on, most had a VSD, and 17 died soon after the operation, sometimes the same day, or the other day, next day. 8 died subsequently, but 20 were alive 53 years after the operation. And here just shows something about the number of patients, 27 VSDs, 10 patients with tetralogy flow, 5 patients with AV canal, 1 ductus arteriosus, which was the diagnosis is VSD with pulmonary insufficiency, but it was found a VSD, coupled with pulmonary stenosis. I might just comment about this one patient living with AV canal. She was from Canada and had been adopted, so she came down with 2 last names. And then she returned to Canada and was married and divorced 3 times. So she had 5 last names. And it's hard to find her phone number. But finally enticed one of her former husbands to give us her phone number. And we called her. She was doing well and was just so excited to hear from us in the fact that we were interested in her long-term follow-up. And this is just a curve showing here's the time after surgery and the survival. So here's the survival rate at 53 years after the surgery in these patients. And we, at 60 years after, we invited back patients who were from the Twin City area. And this man here was the second patient to have this type of procedure and was the first survivor. He had a ventricular septal defect, and he died a couple years ago at the age of 65 and had a VSD repair. It was interesting, his VSD was a perimembranous ventricular septal defect, and they didn't quite, and it was hidden underneath the septal leaf of the tricuspid valve. And so when they did the operation, they cut the cordi to this tricuspid valve to get to the VSD and then tried to sew those back. And so he put that type of valve. He went a number of years, but when he was about 49, he had to have the tricuspid valve replaced. So he was the second one. And this lady was the third patient to have, and her VSD is repaired. The woman in red was the 5th. The man in the blue shirt was 37th, and the woman in the blue dress was the 8th patient. And on the far left is Vince Gott. Interesting about Vince Gott, he was a roommate of Paul Quee, a longtime pediatric faculty member in the department, and they were roommates all through Yale Medical School. And Paul said, I only had 2 roommates in my life. One was Vince Gott, and the other is my wife, Betty. But these are survivors from that era. Well, here are the 4 who were involved in this. Up in the upper left is Walt Lilleheim. And on the upper right is Herb Warden. Lower left is Morley Cohn, and the lower right was Dick Varco. And these pictures were taken at the time they won the Lasker Award, which is kind of the American equivalent to the Nobel Prize, but they won it for cardiac surgery. This morning, Tom Kulik talked about Dr. Gross and adductus, and it's interesting, he's won 2 Lasker Awards during his career. This is Walt Lilleheim, and you can see this big spotlight on top of the head. Is a wear on the neck, and certainly very different from the types of lights that surgeons use now. Dr. Wagenstein was his special mentor and champion, and he said about Walt, as a true visionary surgeon who created a favorable environment undiluted by the cobwebs of tradition. And he trained 150 surgeons while he was here. at the University of Minnesota. And Denton Cooley, who was a surgeon, the third surgeon to do repair of ventricular septal defects, said, hardly any other cardiac surgeon has introduced a greater number of innovative techniques and concepts. And these included the Bubbleoxidator, the cardiac pacemaker, and the St. Jude cardiac valve. And this was the Pumpoxidator that was used after 1955. It stands about 6 feet tall. It was developed by Dick DeWall. Dick DeWall was in family practice up in St. Cloud, Minnesota. And after 18 months there, he was not very happy with his practice. And so he came down and talked to Dr. Wagenstein about becoming a surgical resident here. And he said, well, I don't have any positions, any money to support you as a resident, but I could support you as a laboratory technician. And Dick DeWall jumped at it because it paid more than being a resident. And Walt told him, said, I don't want you to read anything about these things, Pumpoxidators, and I don't want you to bubble oxygen through blood. Well, I don't know if he read anything, but he did start develop this Bubbleoxidator. And down here is an oxygen tank, and the oxygen would flow into this tube, and into this tube also would come the systemic venous blood. And so the oxygen in the blood would rise up this tube, and this is kind of called the debubbling chamber. And there's something like steel wool in here. And so the blood would then flow down here, and this steel wool would pick up any debris from platelets or particles, and then run down this helix all the way down, and then the arterial blood would come out here and be pumped into the patient. This is a very primitive device, but it worked. And they found out that they could do this all in a plastic bag. And so DeWall and Vince Scott developed this technique where they could put the blood oxygen in this tube, and it would come down through this technique, and then the arterial blood would come. Very simple thing. It cost $25 and worked very well. So this replaced that tall device that we saw previously. And so by the summer of 1955, he had this Bubbleoxidator, which cost $25. And the Mayo Clinic in Rochester had picked up the given oxygenator, which had been developed in help with the IBM Corporation in Pennsylvania. It moved to Rochester, where the IBM had a facility, and became the Mayo Given oxygenator, and was used by Dr. John Kirkland. Well, here's an interesting photograph taken in the Smithsonian Institute in Washington, D.C., of one of these early Bubbleoxidators. And this woman is Dr. DeWall's granddaughter, and here's Dr. DeWall's great-granddaughter, and little girl here, obviously looking at this Bubbleoxidator. And about a month later, this little girl had her ventricular septal defect closed using an oxygenator similar to what her great-grandfather had developed. Another development was a cardiac pacemaker. And these were developed here at the University of Minnesota. And they're external, early ones that wore around their neck with a bag. It had dials on the surface. And in those days in the hospital, we didn't have television. The children didn't have television to watch. The dials were right out there in front on these pacemakers so the kids could fiddle with their dials. And so they then learned to recess these dials and eventually put a plastic cover over these pacemakers. And these were developed by Earl Bakke. Earl Bakke was head of electrical service at the university, and he was in charge of repairing any electrical problems around the hospital. And so when this problem came up that they needed a pacemaker, Walt talked to him, and Bakke said, I just read in Popular Electronics an article entitled 7 Projects You Can Make with 2 Transistors, and one of them was a metronome. And a metronome, remember, the metronomes used to be on every piano in the United States. And so he used that type of circuit, to develop the first pacemakers. And he developed them in a double garage up in North Minneapolis with his brother-in-law. And eventually these this garage became the headquarters of a company that was named Medtronic. And so Earl Bakke was the person who really set off the movement for cardiac pacemakers that have been so successful. One of the first patients to ever be paced was a little girl from Buffalo, New York, who on July 30th, 1957, had an operation and afterwards had complete heart block. And complete heart block post-surgically was almost universally fatal. And so the surgeons went over to the physiology laboratory and got a GRAS stimulator, which is used to study myocardial contractility, and used this to pace the little girl's heart for 2 or 3 days. When she recovered, they sent her home on rectal isoprel, which is the only treatment we had for that. And about 4 months later, she died. And so on 50 years later, Vince Gott came up from Johns Hopkins, and I came out from Minnesota, and we had lunch with this family. They're an Italian family, and then we had lunch in an Italian restaurant in the back room of this Italian restaurant. And it's very special to eat in the back room of an Italian restaurant. And the mother and father were there. And so this little girl's brothers and sisters, who were now adults, and the grandchildren. And the father, who was sitting opposite me, said, I've had a couple of episodes where I passed out suddenly, and next week, I'm going to get a pacemaker. And not knowing that his daughter was a pioneer in this whole process of pacemakers. Well, this is from Denton Cooley, who has passed away since here is no longer a contemporary cardiac surgeon, but said, Walt, you brought the can opener to the largest picnic that cardiac surgeons ever had. Which is probably true, that he opened up the whole area of cardiac surgery. In closing, I'd like to thank 3 people who helped very much putting this together. One is Mary Jo Antonazzi, my long-term secretary. June Willis, who worked for me for 28 years, came in once or twice a week, helped track down patients, particularly in a 1,000 patient study that we carried out for 50 years and had, there were 992 of the 1,000 were at 50 years and see a pattern. One other, I'd just like to close with one other comment. You could turn it up. The best years of mine at the University of Minnesota were between in 1960 and 1980. We had a tremendous group of people there, people such as Howard Burchell, who is the editor of Circulation, Jesse Edwards, internationally known cardiac pathologist, a great teacher who was one of my mentors for 50 years. Kurt Amplatz, known as Amplatzer device, but he was a terrific radiologist and interested in congenital heart disease. He knew a lot of the physiology and findings in congenital heart disease. Richard Varco, a surgeon, and then two pediatric cardiologists, Ray Anderson and Russ Lucas, who was another one of my mentors. And we'd be in a meeting together, and we could disagree, but we were not disagreeable, and we could talk and converse and learn from each other. And it was a magnificent educational experience, and one that I'll always remember. So thank you very much. I hope you've enjoyed your lunch.